Okay, hello everyone. Welcome back to another PS Platypus lecture. Today we're going to be continuing on the theme of immunology with two very important topics, which are immunodeficiency and autoimmunity. Now, I've decided to lump these two together despite them being separate lectures because they're essentially two sides of the same coin. So in immunodeficiency, we're going to discuss what happens when the immune system isn't working as it should. In other words, it is not as powerful. Whereas in autoimmunity, we're going to discuss when the immune system is either working too hard or it's working on the wrong things. Okay, so that's why I've lumped them together, and hopefully this will give you a clean, concise overview of both topics. A reminder as well that if you want a little bit more detail on these particular topics, my notes have been linked in the PS Platypus shared drive. So if there's any questions or concern you have a look at those notes first. But if there's still anything that confuses you, please don't hesitate to message me. All right, let's get started with immunodeficiency. So firstly, just some definitions to get out of the way. You've got primary immunodeficiency and secondary immunodeficiency. And much like anything that we call a primary condition or a secondary condition, primary is something that we really don't have much of an idea for what causes it. But we can say in this case that it's either, really rare conditions or they're congenital disorders. And they're generally things that are not influenced by the environment or they're not acquired essentially. So some of the key characteristics of a primary condition includes a history of repeated infections with the same or similar pathogens. So that sort of history can kind of point you towards this being more of a primary cause. Usually it manifests very early in life because most of the time it's a congenital disorder. And generally the mutations happen in recessive genes. So that's often why X-linked conditions are common in males because you only need one copy for it to essentially occur. And the clinical manifestation can be very variable. And there's multiple reasons for this. One, of course, they can happen in different genes. Even if it does happen in the same gene, they can either be point or frame shift mutations, which, if you remember back to year one, have very different effects. Patients also, even if they have the same genes or same gene mutations, they also have very different genetic backgrounds. So that can cause them to have different responses and phenotypes. One example you go through is, I think, an IgA condition. So that's a classic example of how even though people have the same mutations, they have different outcomes. And also where in the immune system that protein is actually being expressed. So is it in a B cell pathway? Is it in a T cell pathway? Is it an innate immune response pathway that this protein is in? And therefore the lack of it will cause a slightly different outcome. Secondary immunodeficiency is a little bit easier to understand. So it's generally environmental factors and acquired things. You generally tend to see them a lot later in life compared to primary immunodeficiency. And some of the causes include infections like HIV and AIDS, measles, malaria, malnutrition, especially in kwashiorkor, so protein deficiencies, cancers, especially those that obviously affect the immune system, like a lymphoma, and treatments that target rapidly growing cells, of which immune cells are one class. So that can be chemotherapy, radiation, and immunosuppressive medications. Now, this table is kind of nice in terms of just telling you the difference between, as I kind of mentioned before, it depends on which specific arm of the immune system that protein is being expressed in, and therefore defects in that arm will lead to specific outcomes. So if you are looking at the innate immune defenses, so at the very bottom, it's generally quite variable what sort of things will happen. So you can get a lot of bacterial infections, but you can get viral and all sorts of other things. I think with B cell and T cell, they're all easier to understand. And the reason why is because B cell deficiencies generally have extracellular targets, and that's mainly bacterial. So when you have a B cell deficiency, most of the patients will have pyogenic bacterial infections as their main problem. Whereas in T cell deficiencies, because T cells tend to target more intracellular pathogens, such as viruses, you tend to have more viral infections, as well as some other things like some intracellular fungi, intracellular bacteria, and so on, but mainly viral infections. So hopefully that makes a lot of logical sense. Now let's get to the actual meat of this topic, which is the different conditions that you need to know a little bit about. Now, all of these slides contain quite a bit of detail. I will only really be focusing on the things in bold because I feel like overall this is a very low yield topic, but if you get a question on it, it's very easy for you to pick the right answer. So firstly, with chronic granulomatous disease, the definition is something just to remember. So it's a deficiency with innate immunity. We're going to focus mainly on innate for the time being, where phagocytes cannot destroy pathogens. So yes, they might be able to actually consume them, but when it comes to destroying the pathogen, it's not able to. And the reason why is they have a mutation within a phagocyte enzyme known as the NADPH oxidase enzyme. It's used to produce toxic superoxides in the phagolysosome. When the phagocyte and the lysosome sort of combine together to digest the pathogen, it's not able to produce the enzymes that are actually going to be able to destroy it. That particular enzyme, very large complex, and it's got a GP91 component on the X chromosome, which is most likely going to be mutated. You don't need to know that. I don't think they'll ever ask you for the specific gene component. Symptoms will include persistent infection in the first 2 years of life. So, of course, because it is a genetic defect, you'd expect it to be quite early. It's a primary immunodeficiency. This includes pneumonia, lymphadenitis, skin abscesses, and visceral infections. It's most often caused by non-pathogenic organisms. So Staph aureus exists in a lot of different places on in your body, including the skin, but you tend to have more infections because of these organisms in conditions that are compromising the immune system. Because your phagocytes can't destroy it, they instead do something which is trying to essentially wall off the pathogens, right? Because they can't destroy it, they're just trying to keep it away from everything else, and that's what you essentially call a granuloma. Treatment-wise, prophylactic antibiotics to avoid those infections, anti-inflammatories to reduce the inflammatory response, and then eventually a hematopoietic stem cell transplant, because you essentially can't cure this without having a complete overhaul of the immune system. And here's just a diagram showing you some of those words. So I've just kind of, on the left-hand side, you've got the diagram showing how that phagolysosome process is supposed to work. So the reactive oxygen intermediates and how those are actually produced. And on the right-hand side, I've got the GP91 protein, as well as a couple of other proteins that are responsible for the signal transduction process. And as I mentioned before, GP91 is the one that tends to be mutated the most, but you don't really need to know that in too much detail. Okay, another condition. So leukocyte adhesion deficiency. In this case, phagocytes really do want to digest and destroy the pathogens, but they just can't stick on to the site of where the infection is happening very well. So essentially, they cannot adhere to the epithelium. And here it's a mutation in another protein called CD18, which is a beta-2 integrin receptor. So if you remember back to integrins back in, I think, semester 1, year 1, things that allow for the immune cells to actually roll and adhere to the epithelium before they then extravasate into the site of the infection. If you have a problem with the integrin, it's not going to be able to hold on and therefore won't be able to go to the site of infection. So integrin is a heterodimeric adhesion molecule, which has alpha and beta subunits. And essentially you have a problem with the beta-2 subunit. And some of the proteins that are involved include LFA1 and MAC1. Okay. Symptoms, autosomal. So it's an autosomal recessive disorder, and it leads to a lot of fatal bacterial infections. So you can have mostly genuine infections rather than opportunistic ones, like you saw in the previous chronic granulomatous infection. And commonly the things that you can see are severe gingivitis and high plasma white blood cell count. Delayed wound healing is often the first sign. So you can actually get, when a baby is born, they can get really slow umbilical cord separation because they're not able to really cut off the umbilical cord in an effective way like a normal baby can. Treatments include, of course, prophylactic antibiotics to avoid the infections, and then eventually, similar to chronic granulomatous disease, you need a complete overhaul. So a bone marrow transplant can be indicated. So here is, again, a diagram on the left-hand side, which shows where the problem is happening. So remember, I alluded to the fact that in semester 1, year 1, you would have gone through this whole process of rolling adhesion, going down into migration. But at the point where you have the binding, if you're missing that protein, it's not going to go any further. And on the right-hand side is just a cute little cartoon showing the fact that the leukocyte really does want to destroy the pathogen, but it's not able to really hold on to the endothelium because of CD18 not being present. Okay. Now, there's this cluster of conditions called severe combined immunodeficiency, or SCID. It's a series of genetic defects that causes defective development of T cells. So now we're moving away from innate immunity, and we're going towards the cellular immunity. So you've got complete ablation of T-dependent immunity, as well as the antibody response, because we know the antibodies really require T helper cells to first stimulate them and tell them to start being produced from B cells. You also have problems with development of B and NK cells because everything really starts with the T cells being functional. So they can be affected, which means you have very few peripheral lymphocytes present. And it can also affect the development of the thymus gland because that's where T cells mature. So you can see on the right-hand side, you've got a normal thymus gland and you've got a skid thymus. I can't tell you what the major differences are, but you can see a lot of atrophy. So you don't need to remember the histology. You just need to know that thymus can be affected. And there are three main skids that you need to remember for the exams. You've got the common cytokine gamma chain receptor problems, which are X-linked. And all of these have a different sort of phenotype. So with this condition, you have normal amounts of B cells, but your T cells and NK cells are not there. We'll go into why that's the case later. You also have Vdj recombination error. Not sure if you've gone through Vdj recombination in first year. We didn't really do it, but we kind of went over it in this lecture anyways. I will explain that when we get to the slide. It's an autosomal mutation in either the RAG1 or 2 enzymes, where you have no T cells or B cells, but your NK cells are normal. And we'll go again into the reason why that's the case. And then finally, Purine salvage pathway enzyme error, which is autosomal. And in this case, you have nothing. So no T cells, no B cells, and no NK cells. So in some ways, it's the most severe one. Okay, so just the core things you need to know. With common cytokine gamma chain deficiency, it's X-linked and it can lead to SCID. So the gamma chain is the signaling component of the receptors that responds to a lot of these cytokines that a lot of these cells use. So you can see that in the diagram here. You've got the gamma chain. It's attached to a lot of different proteins. And essentially, it's attached to a system known as the JAK-STAT signaling system. So it's tyrosine residues that are phosphorylated by the system. And then essentially the signal transduction leads to gene expression at the very end, and it's crucial for the development of T cells and NK cells specifically. So just remember the B cells are not really subject to this type of signaling. It's mainly T and NK cells, which means if you have a deficiency, you're not going to be able to get development of these cells. And you can see that the main cytokines that are responsible for the NK cell and T cell development are IL-15 and IL-7. Okay. Now, with the Vdj recombination error, firstly, just a bit of background on the Vdj process. You essentially, so Vdj stands for variability, diversity, and joining. And essentially, it's how you get the recombination of all of these cells. So you have B cells and T cells and how their receptors get recombined to avoid self-recognition, as well as to make sure that you have a huge amount of variability to detect any foreign antigens. So that's what Vdj rearrangement is. Apologies for the interruption. I think my computer died at the last minute. I'll combine the two videos together. But essentially, I was talking about the importance of the Vdj rearrangement system and the fact that this allows for random recombination of gene segments to ensure that we have a huge amount of variability in the receptors that we have on the T and B cells. Now, in order for this process to happen, you need RAG enzymes to be functional. So these are RAG1 and RAG2. They are essential for the recombining of the antigen receptor segments. Without them, your lymphocytes can't express specific antigen receptors because now you don't have the variability. And therefore, those particular cells are never positively selected for, which means you have a very, very severe shortage of some very important phenotypes of T cells and B cells. So that's why you have this particular condition leading to SCID. The last one, which is perhaps the most extreme one, is a purine salvage pathway error. So this is an autosomal condition. And what happens is that you normally have enzymes that are responsible for nucleic acid catabolism, so the breakdown of nucleic acid. But if you have a deficiency in them, then you can get a lot of toxic metabolites being accumulating inside fast-growing cells that are obviously going to have a lot more nucleic acid because they're replicating very, very quickly. So some of these enzymes that are required for this process to happen and to avoid metabolites building up are ADA, the most important one, so adenosine deaminase, and you have a lesser expressed one, which is PNP, purine nucleoside phosphorylase. And you can have deficiency in either of these, but as you can see on the right-hand side, 25% chance of, if you have two people, so you have a father and mother with a mutant allele, they have a 25% chance of passing on the ADA SCID variant. PNP is also a thing, but it's less common. So I would recommend just remembering the ADA one. And this generally affects all lymphocytes because, as you can imagine, B cells, T cells, and NK cells are very fast growing and they're required constantly. So all of them will suffer some form of damage, which makes this one of the most dangerous ones. Okay, how do we treat SCID? So the reason why I put a bubble on the side here is because you may either remember from the lecture or have seen in TV shows or movies before that a lot of people who have this condition in the past were forced to stay in a little bubble that kind of separates them from the outside world, because even if they have the most basic infections, such as just the common cold, or even if there was some sort of viral infection going in the air around them, if they were to contract that, normally most of us would be able to clear them very, very easily. We wouldn't have been able to tell that we had that infection. But in a patient with SCID and very severe SCID, this would be something that could even be fatal, right? Or life-threatening. So that used to be something in the past that was done. But nowadays, there's a lot more, I guess, better things that we can do to ensure better survival rate. So one thing we can do is a bone marrow transplant, which if you match them with family donors has a very good prognosis. There's a kind of a funny thing here because, SCID patients, they don't have T cells or a lot of the other immune cells, which means technically they wouldn't be able to reject a bone marrow transplant graft. However, for some reason, only if you have very closely matched grafts, so what we call syngeneic grafts or MHC identical grafts, will this still work very well. Because if you have an allogeneic graft, the graft can still recognize the recipient as foreign. So it kind of works the other way around. Instead of the recipient cells thinking the graft is foreign, the graft, because it's the one that has all the cells in it, it looks at the recipient and thinks, okay, this is foreign, and the graft attacks the recipient. So you still get a graft versus host disease, but it's for a kind of a different reason than what you would expect. Okay, so just remember, family donors are the best, or at least something that is very, very closely identical to what the recipient had. Enzyme replacement therapy is also one thing. So especially in the previous disease we talked about, when you have enzyme deficiencies, you can do injections. For example, if someone is deficient in ADA, you can give them that, as well as gene therapy. So this is something that is kind of more novel, and it has been tested with the ADA and gamma chain deficient patients. So for previous conditions we discussed, sometimes you can have a viral vector that delivers those into the cells. You can insert the genes into hematopoietic stem cells and then inject them back into the patient. So not something that you need to know a huge amount of detail for, but just know that SCID has, the scientific community has developed a lot better treatments for SCID than just having to isolate them. And obviously that's not a good quality of life. So this is much better. Finally, we've got some lymphocyte related conditions to know. And I'm guessing they don't spend too much time on these, and it kind of shows you that you don't need to know a lot. But I've put as much detail as was put in the lectures here just for your reference. I've highlighted the major things for you to know, though. So the first one is X-linked hyper-IgM syndrome. And the main thing to remember here is that is a mutation in CD40L, which prevents isotype switching. So normally what happens is that you have your IgM response, which is the initial response to any pathogen, but then you need to switch to something that's a bit more specialized, right? You switch to IgG, IgE, whatever is required for the specific antigen. Some background things to know are the concept of a germinal center. So it forms in humoral responses within lymphoid organs. Normally what happens is that IgM antibodies are launched first, as I said, in response to any infection, but then you need to switch often to IgG, and some cases you might switch to IgA, such as in the respiratory tract, or IgE. And this switching is T cell dependent. So T cells are very, very important for a lot of things. Specifically in this case, you need to have the CD40 ligand reaction happening. However, this ligand, which is expressed on T cells, if it doesn't work, so in a case of gamma globulinemia, you don't have that CD40L gene being functional, and it's generally expressed on the X chromosome, which means that your B cells only produce IgM. They don't get any signal telling them to switch. And even though IgM, as you can sort of see on this side here, IgM is a pretty heavy duty antibody, right? It's got sort of 10 different antibodies in sort of this pentagon. While it is very effective in latching onto a lot of cells, it is quite low affinity. So if you have a pathogen which requires a lot more high affinity antibodies, sorry, I blanked out, high affinity antibodies to latch onto it and destroy it, IgM might be able to latch on, but it might not actually neutralize them. So it's not going to be very effective. So you get no germinal centers being formed. and therefore this patient is going to be very prone to bacterial infections. So the way we can treat that is by replenishing the different immunoglobulins that they're deficient in, so that you can artificially allow for that switching to happen, if that makes sense. And obviously prophylactic antibiotics, and then eventually a full hematopoietic stem cell therapy or transplant to ensure that this is cured. The other type is X-linked lymphoproliferative condition, which is a mutated SAP gene, which prevents signaling within between lymphocytes. So the lymphocytes are essentially unable to talk to each other. The background for this is to know just what SLAM and SAP are. So really fun mnemonics, but SLAM is a family of cell surface molecules expressed on many leukocytes, and they're essentially allowing for communication between all the cells that are going to eventually destroy the pathogen. The T cells, B cells, NK cells, and a lot of other stuff. It interacts with SAP. So as you can see over here, SLAM and SAP interact with each other, eventually leads to downwards activation and then killing of the target cell, whatever it is. Now, both of these need to be expressed on the NK cell and the T cell to allow for this killing mechanism to go ahead. And the key thing to remember here is that it specifically targets B cells that are infected with EBV, so Epstein-Barr virus, and have then transformed into lymphomas. So as you would expect, if you have an absence of SAP in this particular condition, you're not going to be able to control a lot of bacterial infections, but more specifically, viral infections, but more specifically Epstein-Barr virus, which is also known as infectious mononucleosis. Okay, so then you can have patients who have contracted EBV who are more likely to develop into a lymphoma than other patients, right? So you need to make sure that they don't have this condition. No matter how rare it is, it's still important to make sure it's not there. Okay, now moving on to hypersensitivity. So this is the opposite problem. This is where I guess we can go to the definition. It's an injurious or pathological immune reaction which reflects either excessive or aberrant immune response. So either there's too much or the immune system is focused on the wrong thing at the wrong time. So there's a nice mnemonic to remember the 4 different types of hypersensitivities, which is acid. So type 1 is classically the allergic type, which is also known as an immediate type hypersensitivity, which mainly involves IgE antibodies, but it also involves the Th2 cells, mast cells, basophils, eosinophils, etc. Classic things include bee stings, latex, as well as certain medications like penicillin. Type 2 is cytotoxic. So essentially it's antibodies that are being produced, mainly IgG, IgM, but also other stuff like IgA complement can also be a part of it, as well as the Fc receptor part of the antibodies. Type 3 is exactly the same thing. So you have the same components being involved, but instead of being just a single antibody, it's an immune complex. And we'll go into what the difference is a little bit later. But you can have a look at the different conditions that are responsible here. I don't think you will cover any of these to much of an extent in any of your lectures, to be honest. These are things that you will come across more when you get into 3rd year, 4th year, and specifically focusing on conditions. But it's just a good idea to know the main difference between type 2 and type 3, because they're both antibodies, just in slightly different targets. Type 4 is T cell mediated. So there's no antibodies involved whatsoever. And it's a delayed response because it actually, the other 3 can happen immediately, whereas type 4 takes a little bit more time, up to 1 or 2 days for it to actually happen. And it's because it's actually the T cells that are responding, which takes a lot more time to kick forward. And here's a nice diagram just showing the main differences. I want you to focus primarily on the type 2 and type 3, because you can see that in type 2, the target is actually antibodies on the surface of a target cell, whether that's a foreign antigen like a pathogen, or that self cells that have actually been changed because of a viral infection or something like that. And there's also a component of complement if you're not looking at antibodies, but really the complement activation is usually a consequence of antibodies anyways. The type 3 response is when you have an immune complex forming, and then you have some sort of immune cell going and digesting the immune complex. So different conditions necessitate either just a pure antibody response with plus or minus complement, or if it's something that's a bit more difficult to get clear of, you might have to develop an immune complex. So that's the main difference between type 2 and type 3. Okay, let's focus on type 1 first, because I feel like that's the most high yield one to know. There's 2 steps that happen. First, you have your first exposure, so the sensitization phase. And I'm sure you've covered this to some extent in first year, but just as a refresher, you have dendritic cells which detect some sort of allergen. It presents it over to the Th2 cells, so the T helper cells. They secrete interleukins, a bunch of signaling molecules that drive the B cells to secrete antibodies, and specifically IgE antibodies, which are involved in the allergic response. These IgE antibodies bind to receptors, so specifically the Fc epsilon receptors, but I don't think you really need to remember that, of the mast cells that prime them. Then you have the secondary exposure. So now you've got these primed mast cells that recognize the fact that there's a specific, so they have a specific IgE antibodies that are bound onto them. So in the secondary exposure, you just have the same sensitizing agent being presented back to the primed mast cells, and they degranulate because now they've recognized it and they're ready to then release all of their proteins that they've been storing inside them. So they get activated, release their granules, and in the immediate phase, they release vasoactive amines. In the late phase, they will be driven mainly by cytokines. And the reason why we've made this distinction between immediate and late phase is because they actually look quite different phenotypically. So if I'll skip to this slide and come back to the previous one. If you have a look here, you can see that in the immediate phase, you've got a pretty rapid response. And in the late phase happens even 1 to 4 hours after the actual initial antigen exposure. So that's really key to understand, is that in the immediate phase, you have a response, but you can also have a late phase response. And if you're presented with a picture of what that response looks like, if you have a look at the immediate phase response, you can see that you have this very localized cellular response, whereas in the late phase, you have a more fluid edema response that happens even hours later. Okay, so that's the main thing to remember, and we'll come back to that in a sec. So here we go. What happens during degranulation? You have the allergen binding to the IgE at the mast cell surface, and it cross-links with those Fc epsilon receptors. Signal transduction, which really leads to the release of those granules and leads to vasodilation and edema. Vasoactive amines, proteases, lipid medias like prostaglandins, leukotrienes, basically just a cocktail of cytokines. The late phase is a cellular response, and it's mainly eosinophilic, and it's mainly through the TNF cytokines, which leads to inflammation and more cellular response. So essentially, if you were to remember anything from this, it's mainly that the immediate response is vasodilation and a very localized edema, whereas the late phase is more cellular infiltrates, and it's generally eosinophils that are involved here. And one thing you can do is to use a skin prick test or even lung function tests in the case of asthma, but mainly skin prick test to see if this particular allergen is going to lead to a response in a patient. So I suspect that's what's actually been done in this picture. They've got a patient and they've exposed them to an allergen on the arm. And what's happened in the immediate phases, they've got that small amount of fluid and cellular response, but in the late phase, you've got even more of that happening, so hours later. Okay, now how do those Th2 cells actually lead to a type 1 hypersensitivity? And why does it happen? Because Th2 cells are supposed to be things that help us, right? So why do they lead to a hypersensitivity reaction? Well, the Th2 cells are primarily involved in what's called a weep and sweep response, and they are in response to suspected parasites within mainly the GIT and the lungs. So type 1 hypersensitivity happens when your body essentially thinks there is a parasite within one of the organs or one of the systems, and it launches this response, but actually there is no parasite there. And it's still a topic of debate into sort of why that happens in some patients and not others, but we suspect it's because there is more of a Th2 response than a Th1 response, so there's an imbalance. The clinical syndromes that you can see revolve around mucus hypersecretion and smooth muscle contraction. So the main ones that you should know at this stage is asthma, but there can also be an atopic triad. So asthma, dermatitis, and eczema, as well as the acute anaphylactic reactions. So in asthma, the main one that we want to focus on here is your body essentially thinking there are worms in the respiratory tract and then initiating the weep and sweep response, which is contracting the smooth muscles and then generating more mucus to kind of get all of that parasite out of the lungs. So the hygiene hypothesis is something that you will go over very briefly, but it kind of tells you that this sort of area is one where there's a lot of overlap between genetics and environment. And there are some hypotheses that shows that hygiene or the exposure to parasites and bugs in early life actually has a big effect on whether someone develops asthma or dermatitis or eczema in the future. So the normal non-allergic responses are Th1 mediated, the allergic response is Th2 response, and in the patients who have this, Th2 overrides Th1, or you at least have more Th2 than Th1. Allergen immunotherapy is also just something that I've popped in here because it is fairly low yield, but it's a cool concept to know, is that if you have someone with asthma, then one potentially like close to curative technique you can do is to continually expose them to small amounts of a particular allergen that causes them the response. So you give them a very small amount and increase the dose as you go along. And what you should find is that their Th2 response goes down because now they're getting more and more used to this particular allergen. And the non-allergic response via Th1 goes up. So you're restoring that balance essentially. Okay, so it's just a concept to be familiar with, but it is something that is, you know, like we like to think it's curative, but it's not usually always going to be 100% curative and doesn't work for all allergens. So classically, the skin allergens are very easy to do with this, but not all allergens will actually be able to be fixed with this sort of immunotherapy. So it's a developing area. Okay, what about type 2 hypersensitivity? So when you have these antibodies, remember that with type 2, unlike in type 3, you do have antibodies, but they're against cell surface targets. So that's either on bacteria or on host cells. As a bit of background, the Fc receptors are found on the innate immune cells, and they recognize any antibody-antigen complexes that are made. So NK cells, they activate the antibody-dependent cellular cytotoxicity or ADCC reaction. Phagocytes release pro-inflammatory cytokines and then phagocytose the antigens. And there are also some other phagocytes like neutrophils that can degranulate and destroy antigens. You also have the activation of classic complement system. And the complement system is something you would have gone into a lot of detail in year 1. It's not really that relevant here. The main portion is going to be the antibodies. And the conditions it's associated with are Graves' disease, which you will go over to some extent later on in the year, or you may have already done that in the previous semester, myasthenia gravis, vasculitis, and autoimmune hemolytic anemia. Okay, type 3 hypersensitivity is instead of being targets on cells, it's actually immune complexes, so a mix of the antibodies and the particular antigen that you have. However, normally those immune complexes they get cleared out very quickly, but in some conditions or in some patients, they're not able to be cleared out. So those, essentially what happens, or I like to think about it, is that those immune complexes get stuck somewhere and your inflammatory response tries to go there and initiate some sort of response, but it's not able to clear it. So you have a chronic response in a particular tissue where that immune complex got stuck. So in urticaria, you have, or hives essentially, you have a complement that is mainly in the skin, and that leads to mast cell activation in the skin, and then you get this sort of rash developing. You can also get purpurae because of the immune complex getting stuck in blood vessels. And when you get the immune response, because those blood vessels are quite fragile, they can hemorrhage and lead to these sort of hemorrhagic spots underneath the skin. There are also more extreme versions of this where you get them depositing within organs, so specifically in SLE or in some forms of glomerulonephritis that affects the kidneys. And then finally, in type 4 hypersensitivity, this is completely independent of antibodies, so it's very separate, and it's mainly through T cells. It's delayed because it takes about 24 to 72 hours for patients to even show symptoms. So it's Th1 cells that recruit macrophages, neutrophils, as well as T cytotoxic cells. Some syndromes include hypersensitivity, especially contact hypersensitivity, type 1 diabetes, and multiple sclerosis. So one really interesting example that they go over in the lecture is contact hypersensitivity to poison ivy, which in some people leads to raised red oozing blisters. It's in response to a particular, I guess, chemical that's found within the plant. I'm not even going to try to pronounce that. That binds covalently to skin cells, and those cells then get ingested by macrophages, which presented on MHC2 cells as they do. That migrates to the lymph nodes to stimulate T helper cells, and then therefore a cellular response, and that leads to the edema and cellular infiltrates. So the way we can treat that is corticosteroids because they are immunosuppressive, and you can also administer, you can't administer antihistamines because there are no mast cells involved. So this is something where, if you try and administer antihistamines and there's no response, then you're suspecting it's not actually mediated by mast cells, it's a delayed hypersensitivity. And I've got a diagram here that sort of shows a lot of the diagrams that were shown in the lecture slides, but the main one to focus on is going to be the one at the bottom, which shows why it takes so much time, because there's a whole process that goes on behind the scenes before you then get the edema and the cellular infiltrate that the patient then notices and presents to the clinic with. So I hope that makes sense. I know it's a bit rushed, but it should go over the main topics of hypersensitivity, as well as immunodeficiency. If you do have any questions, feel free to look at the notes that I've posted up or message me, and I'll hopefully get back to you very quickly. I know a couple of people messaged me with questions for the previous lectures, and I want to say it's really, really awesome to see all of you guys questioning a lot of these content, because it is quite confusing. And semester 2 is one of those really tricky semesters. There's a lot of stuff to go through, but I know and I trust that you will get through it. And once you're through it, you will feel very confident in yourself when you approach your clinical years. So best of luck for your studies. Again, if you have any questions, let me know. And I will see you next week for our next set of lectures.